p-tau217 outperforms p-tau217 alone in identifying high tau load in amyloid-positive individuals. It's not the best title for a lightning presentation. And so I have no disclosures. So tau pathology markers have been known to have a better prognostic value compared to amyloid markers, and several studies have highlighted this. And moreover, tau pathology is easier to stain thanks to the characteristic spread pattern that has been seen both post-mortem and with tau PET studies. Indeed, tau PET has been implemented lately in clinical trial designs to try and identify this earlier stage population and try to exclude the moderate to severe ones that have shown to have less clinical benefit. Moreover, there's a strong pipeline of tau targeting drugs, and therefore biomarkers are needed. So we know that 217 is great at identifying amyloid-positive individuals, but in the amyloid-positive, tau-negative population, we can see that there are some tau-negative staged by PET with high p-tau217 in plasma, and therefore a better biomarker is needed for this population. Staging fluid biomarkers have shown promise in CSF. They mostly rely on trying to identify very low abundant tau species that appear later in the disease progression, and therefore the transition from CSF to plasma has not been very easy. So the aim of our study was to try and see if a panel of proteins could improve the prediction of the presence of late-stage tau pathology. We decided to do this by measuring the nulysis CNS panel in the plasma from patients that had tau PET, and possibly improve the screening of this population. So we have two cohorts, Biofinder as discovery and TRIAD as the validation cohort, and we only chose amyloid-positive individuals, and we divided them as BRCA early and BRCA late if they were above stage 4. As mentioned, we used the nulysis CNS panel, and then we used regression methods to try and identify the best predictors among the proteins in the panel. So we used elastic net regression, and 18 out of the 126 proteins were highly selected in bootstrapping rounds. And then further refining the selection with the stepwise regression, we identified a panel of 7 proteins that we called the EN panel. And we can see that all components have a significant odds ratio, and 217 is clearly the most important parameter still. So how does it look in the discovery cohort? We did the classic ROC analysis, and we see a significant improvement in AUC and also in other clinical metrics. And if we plot the predicted probability from the generalized linear model, we can see that the distribution is more towards the extremes, which is what we would like, and the intermediate zone of patients that are hard to classify is slightly reduced. This is also observable in the validation cohort from TRIAD, where we have a significant improvement in AUC, and again, the same pattern in the distribution and a reduction in the intermediate zone. So to conclude, we can see that 217, of course, remains the best predictor. However, other proteins contribute to an improvement in the prediction towards BRCA late stage of tau pathology, and this has been shown in both cohorts. And therefore, a protein panel could be a strategy to achieve staging in plasma without chasing these very low abundant tau isoforms. I will also be presenting a poster today, so you're welcome to swing by. And yeah, thanks to my supervisors and collaborators, and to the Alzheimer's Association for having supported my attendance here today. Thank you. Thank you.
Thank you so much. That was a great talk. We will move on to the second speaker, Catarina Tristão Pereira, who will present on plasma biomarkers of neuroinflammation and neurodegeneration in relation to cerebral glucose hypometabolism in autosomal dominant Alzheimer's disease.
Okay, thank you. Okay, so glucose hypometabolism as measured by FDG-PET is a main hallmark of Alzheimer's disease and is often assumed to reflect neuronal and synaptic dysfunction. However, the pathological basis for metabolic changes is complex and not fully understood. So the objective of our study was to investigate the differential contributions of plasma biomarker to FDG-PET in autosomal dominant AD. And to do that, rather than looking at local brain regions, we leveraged network-based FDG patterns to account for regional interdependencies. So to do that, we used autosomal dominant AD Colombian kindred of presenilin 1 mutation carriers who develop MCI at age 44. In this study, we used 40 presenilin 1 mutation carriers, 5 of whom were cognitively impaired, and 37 non-carriers who had plasma biomarkers and FDG PET available. So first, we computed a principal component analysis on all regions of interest to identify data-driven metabolic networks, and we selected the first 3 components. So the first one explained most variance in FDG data and reflected the default mode network, the second component, the limbic network, and the third component, the salience network, the 3 of which are among the most affected functional networks in Alzheimer's disease. And then we used ridge regression to evaluate the independent effects of each plasma biomarker on these 3 metabolic networks. And we observed that hypometabolism in the DMN-related network was mostly and only associated with higher levels of GFAP when accounting for the other biomarkers. And this suggests a contribution of reactive astrogliosis to glucose uptake that was independent of neurodegeneration. We did not find any associations between limbic metabolism and plasma biomarkers, possibly indicating that limbic regions in ADHD might be later affected by hypometabolism. And then we also found hypermetabolism, so increased metabolism in the salience network that was associated with high levels of plasma NFL. And this was very curious because hyperconnectivity was also seen in the salience network in functional studies and proposed to be a compensatory mechanism that after the DMN disruption. And then finally, we used K-means clustering of plasma biomarkers and the metabolic networks to identify biological subtypes. And when we used the full sample, this method was able to identify the 5 cognitively impaired presenilin 1 mutation carriers who had higher levels of GFAP, NFL, and p-tau, hypometabolism in the DMN, and lower cognition. And when we excluded the cognitively impaired, this method was able to cluster together half of the cognitively unimpaired presenilin 1 mutation carriers who followed a very similar biomarker trajectory. And curiously, again, the cognitively unimpaired had hypometabolism in the DMN and hypermetabolism in the salience network, which could suggest a good biomarker for disease progression. The interaction between networks could be a good biomarker for disease progression. So the takeaway message in the study is that plasma GFAP was the biomarker mostly associated with hypometabolism in regions of early disease and was independent of neurodegeneration. And this suggests that GFAP is a relevant biomarker in early ADHD, but also calls for a more cautious interpretation of FDG PET data as synaptic dysfunction biomarker. And finally, our work also highlights the importance of network-based data to study pathology, specifically metabolic connectivity, which seems to be paired with functional connectivity data. So if you have any questions, please come see my poster today at 4:40, and thanks for your attention.
Thank you very much. Thank you very much for this presentation. Our next speaker is Sindhuja Vigneswaran, and the presentation is a prospective evaluation of a real-world experience with an Alzheimer's blood-based biomarker panel in memory clinics, the CANTATE project.
Thank you for the introduction. I have personally nothing to disclose. Thanks to the development in technology, we are now able to measure these plasma biomarkers in blood reliably. Not only do they show strong concordance with CSF and amyloid PET, but also with neuropathology, making them a promising tool for clinical practice. But how do we translate this to clinical practice? Inga Verberg and team developed threshold and a visualization tool for these biomarkers using 5 clinically relevant questions, with identification of AD being the most important one. They used a retrospective cohort and concluded that a panel consisting of plasma, p-tau181, GFAP, and NFL to be relevant to answer these questions. These were the best available biomarkers at that time. The visualization tool consists of the retrospective cohorts, depicted in yellow as amyloid negative and in blue as amyloid positive, with cut points at 90% specificity and 90% sensitivity. And the individual panel results of a patient is used to predict their likelihood of being amyloid positive. So that could be either low or intermediate if it's between those cut points and therefore difficult to interpret, or high. The aim of my study was to evaluate the clinical utility of plasma biomarkers using these thresholds and visualization tool in a memory clinic population. And we included all patients who visited our memory clinic, and during multidisciplinary meeting where we tried to determine the diagnosis of the patient, we asked clinicians to provide us the syndrome diagnosis, the underlying etiology, and how certain they are about this etiology prior to the blood test and after the blood test. And if there were CSF or amyloid PET results known, then these were shown after the blood test results. Let's move on to the results. We were able to include 450 patients with an average age of 68, and 41% were female. The primary suspected etiology prior to the blood test were most commonly no neurodegeneration and AD. Other forms of neurodegeneration had a much smaller proportion. And we also observed that many of the blood test results ended up being in the intermediate range, both for AD as primary suspected etiology and as differential diagnosis. Let's move on to our primary outcomes. We observed a change in etiology after the blood test in 23 patients, so 5% of the total cohort. But overall, the median diagnostic certainty increased from 80 to 90% after the blood test. And if we dive deeper into that, then we saw that clinicians tend to either increase in their confidence or show no change. And in those where we saw a decrease in confidence, clinicians tend to change in their diagnosis after the blood test. For example, in the MCI stage, we saw that 3 patients changed in the diagnosis. For example, a patient who was initially thought to have MCI due to vascular origin with a differential diagnosis of AD, but the blood test showed high p-tau181, moderately high GFAP, and low NFL. Therefore, the clinician reconsidered and changed the diagnosis to AD. Another example, in the dementia stage, 5 patients changed in the diagnosis after the blood test results. A patient who was initially thought to have AD with a differential diagnosis of FTD, but the blood test showed high NFL and low p-tau181 and GFAP. Therefore, the clinician reconsidered and changed the diagnosis to FTD. So in conclusion, the plasma biomarker panel of p-tau181, GFAP, and NFL provided a modest added value in clinical practice. Overall, the diagnostic certainty improved. However, we only saw diagnostic changes in 5% of the cases. We observed a substantial intermediate zone, and our panel had limited added value for the DLB questions. However, we are currently evaluating p-tau217 and NFL, aiming to reduce these limitations and improve our diagnostic accuracy. Thank you for listening.
Thank you so much. The next speaker is Linda Carlson, and she will present on reference proteins to improve performance of core 1 and core 2 Alzheimer's disease CSF and plasma biomarkers.
Good morning, everyone. I have nothing to disclose. With the revised criteria for diagnosis and staging of Alzheimer's disease, several fluid and imaging biomarkers have been highlighted as core biomarkers, but these biomarkers are not always in agreement with each other, which of course is problematic when we intend to use them interchangeably for diagnosis and staging. Naturally, biomarkers can be more or less sensitive, but there can also be underlying biological factors. In a previous work, we showed that there are individual average differences in CSF protein levels, which can lead to both false positive and negative results when looking at biomarkers for Alzheimer's disease. To solve this, we propose to use reference proteins to normalize CSF biomarkers, similarly to how, for example, CSF A-beta42 is usually normalized to A-beta40. So in this follow-up work now, we evaluated how several core 1 and 2 fluid biomarkers in both CSF and blood were affected by reference protein normalization. We used the Swedish Biofunder 2 cohort and included 1,908 individuals throughout the AD continuum. And then we looked at the agreement between the fluid biomarkers and PET with and without reference protein normalization. in linear regression models. As reference proteins, we used A-beta 40 and non-phosphorylated tau, and to apply the normalization, we applied the fluid biomarker in a ratio with the reference protein. So these results highlight the improvement for the CSF biomarkers when using reference protein normalization. So to the left, we have correlations with tau PET, and to the right with amyloid PET. And the colored part of the figure is the added explained variance during reference protein normalization, with green representing A-beta 40 normalization and blue non-phosphorylated tau normalization. So in general, most biomarkers, CSF biomarkers, improved with this normalization. And if we look at some scatter plots, here is for CSF MTBR tau with tau PET, which was the highest performing biomarker that had highest correlation with tau PET. We can visually see that the linear relationship is increased during reference protein normalization, comparing the raw biomarker at top and the reference protein normalized one in the bottom panel. And same was seen, for example, for CSF p-tau217 with tau PET as well. Moving on to blood biomarkers, we saw a similar result here, that in general, reference protein normalization improved the explained variance with tau PET and amyloid PET, but to a somewhat slightly smaller extent than for CSF biomarkers. And here is example scatter plots for eMTBR tau 243, which improved the most with NP tau normalization in this case, instead of A-beta 40 normalization. And same goes for p-tau217. So in conclusion, normalization of CSF and blood biomarkers to reference proteins enhanced their association with brain tau and A-beta pathology. And even though I did not have time to show it here, these improvements were robust across 3 independent cohorts, both with mass spec and with immunoassays, and when we looked at AT classification instead of linear regression models. These findings are highly relevant for when imaging CSF and blood biomarkers are intended to be used interchangeably. So for example, in the context of the revised criteria for diagnosis and staging of Alzheimer's disease. If you want to learn more, please come by my poster later today. And I would like to end with acknowledging the great group I'm a part of, the Swedish Biofinder study. Thank you.
Thank you very much. Our next speaker is Judith Selma Gonzalez on plasma phosphorylated tau217 predicts cognitive and functional deterioration across clinical stages of Alzheimer's disease.
Okay, so thank you for the presentation and thank you to the organizers for the opportunity to present our work here. So I have nothing to disclose. So as you already know, plasma p-tau217 has emerged as a potential biomarker for detecting AD. And recent studies suggest that levels of p-tau217 are associated with the total burden of tau pathology on Broca stages, and that levels of p-tau217 increase over the time in participants with AD. Despite this, its use remains diagnostic, and the potential for staging and prognosis is still underexplored. For that reason, our objectives were to assess if plasma p-tau217 reflects the clinical stages of AD and if it predicts cognitive decline. So we include participants from the St. Pau Memory Unit in Barcelona, or participants with cognitive assessment and biomarkers as a part of our part of routine care. Then we define AD by the CSF tau181 A-beta 42 ratio, and we divide the participants into 6 stages, the ones proposed by the Alzheimer's Association. Then we use Mini-Mental as a global cognition and longitudinal marker, and we use linear mix effect models for the longitudinal analysis. So when we are going to results looking at the relationship between p-tau217 and p-tau181 levels in clinical stages, we've seen that p-tau181 levels remain stable across 80 stages, while plasma p-tau217 increased progressively with each stage. Then we applied the validated cutoffs of Ashton in p-tau217, and what we've seen is that in participants without AD, but without dementia, had a higher proportion of intermediate p-tau217, while those with dementia were more likely to be positive. And then in participants with more than one measurement, we've seen that both levels of pizza 181 and 217 showed an increase over the time, but the longitudinal rise in pizza 217 levels was higher. Then both biomarkers were associated with a faster decline in mini-mental, and when we applied the cutoffs of p-tau 217, we've seen a faster decline in participants with a positive result, and the intermediate group showed a moderate rate of decline compared to the negative group. So then we built a model, a predictive model for mini-mental decline, and we've seen that the best predictors were plasma p-tau 217, age, education, clinical stage, memory, executive function, but plasma CSF 181 was not in the model, and if we removed p-tau 217, the model performed worst. And finally, we look in participants with AD but without dementia that we built also another model. We've seen that plasma p-tau 217 was, and being stage 3, was associated in a high risk of progression to dementia or stage 4. So as a take-home messages, we've seen that plasma p-tau 217 tracks clinical progression and predicts cognitive and functional decline even in early stages of AD, and this supports its potential in staging and prognosis with clear implications for clinical decision-making and trial design. So this study has been published 1 month ago in Neurology, so if you are interested, you can scan the QR code. And thank you for listening to me.
Thank you. Thank you so much. The last speaker for this session will be joined virtually. So there's a pre-recorded talk from Monika Rimka-Sanotra. And the talk is entitled Combining p-tau217 with other blood-based biomarkers to enhance prediction of cognitive decline, a large memory clinic cohort study.
Greetings all, my name is Monica. I am from Dr. Kakari's lab at the University of Pittsburgh. Today I am going to discuss about our research project related to the performance of combined biomarker for longitudinal clinical progression. As we know, AD is progressive and irreversible neurodegenerative disease, and currently there is no single biomarker which can diagnose AD with better sensitivity and accuracy. Therefore, we evaluate the combination of biomarker for better prediction of Alzheimer's in older adults. Based on revised criteria for AD diagnosis, we included 5 biomarkers in this study, and those were p-tau 217, p-tau 181, BD-tau, GFAP, and NFL. All the plasma samples were included from EPIT-ADRC, which was established in 1985 and having a mission to understand the etiology and pathogenesis of ADRD. Inclusion criteria for ADRC participants are age 60 years and older or a family history of Alzheimer's. There are more than 5,000 plasma samples are archived and multiple assessments are going on. Here we collected 4875 plasma samples which were analyzed by Simua for these targets. After that we did the cross-sectional cohort study. I'm not going to discuss about this due to the time constraint. Then we moved to the longitudinal cohort study. In this study, we include only those samples which were having all 5 biomarker data and have at least one follow-up after 5 years. After collecting all this data, we performed the biostatistical analysis in which we included 2 models, Cox regression model and Kaplan-Meier model. From this demographic table, we can see age, sex, race, education, and ApoE4. All these parameters are significant difference. Therefore, we included this in further analysis as an adjusted value. From this box plot, we can see all 5 biomarkers are showing significant data, but p-tau 217 is showing the highest, followed by NFL and GFAP. From this table, we can see LRT and AIC value. Lower the value, best the result. In AIC, we can see in p-tau 217 and GFAP, which is pretty significant compared to others. And we also try to include third biomarker for the better result, but we haven't found any. After that, we performed the Kaplan-Meier survival curve. We saw low p-tau 217 and GFAP is having the better survival compared to the high p-tau 217 and GFAP. And also, if we look at the HR value, it's like four-fold increased in the high p-tau217 and GFAP. So take home message is that we found like in unadjusted model, all the biomarkers were significant with time to progression. In adjusted model, we saw p-tau217 shows the highest HR value. From the survival curve, we found highest HR value in high p-tau217 and high GFAP with 10 year of medial survival time. So in conclusion, p-tau217 and GFAP could be the good biomarker for the better prediction of AD in older adult with clinically normal participants. I would like to thank all my teammates, my professors and mentors and co-mentors. I also want to thank Alzheimer Association for providing me this conference fellowship. Thank you.
Great. Thanks for all the speakers. Really good at keeping the time this morning. So we have time for questions. Please go through the microphones, or if you're online, we're also monitoring questions. So please don't hesitate to post anything.
Yeah, microphone too. Yes.
Yeah, sure. I'm happy to open the floor. Thanks for a wonderful session. All the talks were really, really good. It's just a question for everybody, really. When we assess the predictive ability of all these plasma biomarkers, when we do see that p-tau 217 outperforms a lot of the other biomarkers, does that ever make you think that then we should maybe leave some biomarkers aside and not really include them in the panels to try and come up with the most efficient way of measuring these things, or is a combined approach always better in your perception?
I can take that question. Sure. So p-tau 217 is essential for the question to identify AD, but what we see in our cohort, in Amsterdam Dementia cohort, is that NFL is also important for the FTD questions. So for us, I think NFL and p-tau 217 will remain relevant.
Yeah, and I can also add that I think, of course, one needs to strike a bit of a balance, right, between the amount of proteins. Like that's why we also try to reduce a bit the panel down to maybe 7, which could potentially be a realistic amount to develop a small panel for immunoassay. Of course, if you included 30, maybe you could get higher AUC, but it also makes it less easy to implement. So
I guess I'm asking maybe when it comes to diagnostic accuracy, which is something that you all touched upon. Obviously, this is not precisely what I'm working on, hence the question, but I'm just thinking, is there a scenario where some results can confuse you, where that can be to your detriment, or is it still better to test more biomarkers to be more diagnostically accurate? Does that make sense?
I think p-tau 217 already has a very high diagnostic accuracy. Almost like 0.95 area under the curve. But I think if we are going to translate it into clinical practice, what we are already doing now, I think we should make it as easy as possible for clinician. And I think you are right in that sense. We shouldn't measure too many biomarkers and maybe stick to like under 5.
Thank you.
Okay, then we have microphone 5.
Great question. Great presentations. Pallavi Sachdev, ASI. Before I make my question, I think I just want to comment on the previous question. It really depends on what we're trying to do. So for diagnostic accuracy, p-tau 217 is great. And that actually leads me to my question. Depending on what we're trying to do. For example, the last presentation on combining 217 with plasma GFAP for predicting progression. Can the panel comment on this? So where do you see the most added value for the development of a panel of biomarkers. So what are the next questions that these panels of biomarkers should address or have the most promise for an unmet need?
I might be a bit biased, but for our study, it was more the staging aspect. So try and see if other proteins also change at different stages, and then joining them in a model could improve the prediction. Yeah, the others have.
Anyone else wants to comment? And maybe along different stages of the disease can be different. Maybe GFAP is better earlier on, but if people have more overt symptoms, then NFL becomes more important. So I think depending which is the population, I think this panel that you're describing could be different, I think. Number 2.
Hi, Ashwini Keshavan, UCL. Just a comment to sort of add to the discussion on the previous, and also a question for Guglielmo. I think another main purpose for developing panels is to index co-pathology, which we really have a poor grasp of right now. And it's probably going to be the next major thing that allows us to identify it and then therefore find ways to treat it. So that's a major aspect. I was struck by, on the NILISA data, Guglielmo, in your paper, that there was a quite wide intermediate range, and this was modulated slightly by the inclusion of certain proteins in the panel, but it was still really quite wide. So when we come to thinking about clinical implementation and proteomic panels like the NILISA, as a clinician, moving forward to the next stage where firstly you need some actual quantification rather than relative quantification, but the next problem is this wide intermediate range. Do you think that this was influenced by the composition of your cohort being very weighted towards asymptomatic individuals? Was that the case?
Like the reduction in the intermediates, so I didn't have time to mention, but the cutoffs I set was at 95% specificity sensitivity, so fairly
stringent.
Yeah, stringent. The more stringent you go, actually, the improvement, like at 97.5, it would have looked a little nicer in the figure, but it's still fairly wide. I didn't really consider so much the clinical stage, so I have to double check. We only selected amyloid positive individuals, so of course some were cognitively unimpaired, and MCI and later stages. So the comparison is a bit like if I had used, let's say, the entire cohort also with amyloid negative, maybe the reduction would be better, but we were thinking more to try and use this panel to answer a bit of a harder question. In this case, to try and, in a, let's say, population where if you would test 217, you could already identify amyloid positive to negative, and then see if a panel could then further refine this high 217 population, but with low, with no tau, let's say, by PET. So.
Yeah, I agree. I think it is worth checking the distribution of the staging clinically as well.
No, thanks.
Then we have microphone 3.
Good morning. Thank you for all the talks. I was late, but so I have 2 questions, actually. One, in the talks I was able to hear, I didn't hear much about NFL. So I'm wondering what you think about that as a biomarker, especially for possible inclusion in combined panels. And then relevant to the final presentation, I'm a clinician, and I typically get 217 and GFAP and NFL. I don't get 181 anymore, and an amyloid ratio. But when you look at a high GFAP, in combination perhaps with a high 217, do you consider that to be only a marker of possible likely progression, or do you actually address the possible underlying inflammation that the GFAP is telling you? Do you actually make any treatment changes? Thanks.
Thank you for your question. So in our cohort, in the Amsterdam dementia cohort, we have developed a panel using clinically relevant questions, so identifying AD, discriminating AD from FTD or FTD from controls, so those with psychiatric symptoms. And there we have seen that p-tau217 and NFL is relevant. We also use GFAP, but it did not turn out to be relevant to answer these questions, so we have left that out. But NFL remained, especially for the FTD questions.
I'm afraid the last speaker, it was a pre-recorded talk, but they're not online, so hard to answer. But I think trying to understand what really is, what a plasma GFAP is reflecting is an ongoing question, so very relevant point.
Sorry, I'm uncaffeinated. I didn't even think about that.
All good. Number 4.
Okay. My name is Pusuno. I'm a neurologist from Bangkok, Thailand. First of all, congratulations. Very good talk to everyone. I have a question for the first speaker. I'm very impressed with all those panels that detect high stage tau. I'm very impressed that it validates well in a independent cohort. I wonder what your next step is into kind of start looking at familiarizing them in the clinic, because as a clinician, I think that I'm very uncomfortable using panels with biomarkers that we don't know exactly how to interpret. I mean, for NFL and GFAP, that's very straightforward. We know different neurons are affected differently, and it's more intuitive. But for panels like that, it's going to be difficult. But given your impressive results, I wonder what the plan is to move forward.
And thanks for the question. So yeah, it's of course not easy because some of the proteins, right, we don't really know yet how they might specifically contribute. The advantage of using the NULISA panel is that the proteins are pre-selected, so they are, let's say, relevant, but of course in a fluid biomarker context, it's perhaps the first times that they show up, and it's hard to explain. So I think, as I mentioned earlier, one needs to find a balance between the amount of proteins and like to have a good interpretability. So we noticed that, for example, the neuropentraxin receptor was also one of the strongest predictors. And maybe for a more clinician-oriented panel, one could also then choose to have 2 proteins. You might lose a slight performance, in a ROC analysis, but of course that's not how clinicians work. So yeah, it's important to have also some sort of interpretability.
Do you have any plan to validate it further in a little bit different population, but still keeping all the criteria and objective constant?
Yeah, that would be great. Of course, it's not so easy to have currently a cohort with the NULISA measurement and tau PET, but otherwise, yeah, would be, of course, very interesting.
Okay, thank you.
Thank you.
Okay, we have one online question before we go to microphone 6, if that's okay. So the question is how to use now p-tau217 for triage or confirmatory testing.
I think that's a good question. That's actually the next project I've been working on. So if a patient enters the memory clinic until determining their eligibility, for example, lecanemab, we have been investigating where should we, in that whole process, implement plasma p-tau217. And for the results we have seen so far, I think it's a good tool for both triaging and for later stages.
Thank you. Then microphone 6.
Thank you. So I'm perhaps the odd one here. I'm a nephrologist, but I'm interested in dementia because more than 50% of our population has some degree of cognitive impairment. So we don't usually send our patients to memory clinic, but now with the blood-based biomarkers, more and more people will have high levels of blood-based biomarkers because these biomarkers are excreted by the kidneys, so they just tend to be higher in people with kidney disease. So what should be our approach to these biomarkers? I mean, primary care will get these biomarkers on our patients. They'll have elevated levels. Where do we go from there?
Okay, so in our previous work, we have seen that on a group level, kidney function did not affect blood-based biomarkers, so beta-217, beta-181. But what we see on case basis is when eGFR is below 60, we do see that the blood-based biomarkers are increased, and that does not correlate with their amyloid status based on CSF or amyloid PET. So I think we should be very cautious with that. And in Amsterdam, we then choose not to use the blood-based biomarkers results for that particular patient.
To rely on PET scans.
Or CSF.
Thank you.
If I can just add to that, I think this is a great example where it might be beneficial to use a reference protein or some other protein that we know also shouldn't change during the disease course, but maybe changes due to kidney disease, for example, and then we can relate it to if that one is also increased, and that would be the more baseline level we would expect the biomarker to be. So I think this is a good approach to handle these kind of situations as well.
Okay, we also have one more question online, which is quite difficult, but what cutoffs to use in the clinics? Does anyone want to take this?
Sorry, I don't know.
What cutoff to use in the clinics for the different blood-based biomarkers?
Oh, what cutoffs? So currently we are using cutoffs based on Uden's index for our clinical implementation, but the other studies where we are determining the eligibility for lecanemab using beta-217, we have worked with cutoffs at 90% sensitivity and 90% specificity with an intermediate range. I think that's the way to go, where you do additional testing in the intermediate, those who end up in the intermediate range.
I would have a question for Guglielmo. It was too fast, so sorry, I was not fast enough, I should say. This 7 protein panel, I cannot quite remember what they were. Like, were you surprised by some of them, or you expected most of them? So I was just wondering if you can comment on what they were.
Yeah, actually, I don't know them all by heart yet, but yeah, let's say, of course, 217 was not surprising. Then we also saw, especially the neuropentraxin receptor that was reduced. With the Alamar panel, in the end, every protein in it is relevant, so it's a bit hard to know sometimes, if it's a bit of overfitting or random, because then when you check the literature, you always see evidence that it means something in AD. Some other ones I think were a bit more surprising, so one needs to investigate for sure further if they. But yeah, and not every protein picked up by this kind of regression system, let's say in a head-to-head comparison, was significantly changed, but then neuropentraxin receptor showed a clear difference.
Great.
Perfect. I think then we can conclude the session. So thank you very much for all the speakers for presenting today, and thanks for attending the session.